A man sits in a quiet exam room looking at a lab report on his phone. One number keeps pulling his attention back. PSA 9.1. He scrolls again, as if the number might change the second time. It doesn't. By the time he meets the physician, he has already searched online, read patient forms, and imagined several possible outcomes. Many people in that situation arrive with the same underlying assumption. If the PSA number is high, cancer must be the explanation. But clinical medicine rarely works that way. In urology practice, PSA does not function as a simple yes or no test for cancer. Instead, it serves as a biological signal, a marker that tells physicians something about activity inside the prostate gland. That activity may have several causes. Some are related to normal aging. Some are related to benign enlargement of the prostate, a condition formerly called benign prostatic hyperplasia. Others involve temporary inflammation or infection. And in some cases, prostate cancer may be part of the explanation. The important question, therefore, is not simply, is the PSA number high? The more clinically meaningful question is, what is causing the prostate to produce that level of PSA? Answering that question requires context, medical history, biological patterns over time, physical examination findings, and sometimes additional imaging or laboratory data. Without that context, a single PSA value can be misleading. And that is where careful medical evaluation begins. In public discussions about prostate health, PSA testing is often presented in very simplified terms. A number below a certain threshold is described as reassuring, while a higher number is sometimes interpreted as a warning sign of cancer. This simplified framing has contributed to confusion for many patients. Historically, a PSA level below 4 nanograms per milliliter was commonly considered within a typical reference range, while values above that level often triggered further investigation. That framework was widely used in earlier screening approaches. Over time, however, physicians and researchers began to recognize that prostate biology is more complex than a single numerical cutoff. Several benign conditions can elevate PSA levels. One of the most common is benign prostatic hyperplasia, a non-cancerous enlargement of the prostate that occurs gradually as many men age. As prostate tissue increases in volume, it can naturally produce more prostate-specific antigen. Inflammation of the prostate, known medically as prostatitis, can also raise PSA levels. Infections of the urinary tract, recent medical procedures involving the prostate, and even certain temporary physiological factors may contribute to a short-term increase in PSA measurements. Another source of misunderstanding arises from how people interpret a single laboratory result. In clinical practice, physicians rarely evaluate PSA as an isolated number. Instead, they often examine the pattern of PSA values over time. Gradual changes, stability across several years, or sudden increases may each suggest different underlying processes. Age is another important context. Because the prostate tends to enlarge with age, PSA values that may prompt investigation in a younger patient might be interpreted differently in an older individual. These nuances explain why PSA screening has been the subject of ongoing discussion within the medical community. The goal is not simply to detect disease early, but to interpret biological signals accurately and avoid unnecessary procedures when they are unlikely to benefit the patient. Understanding this broader context is essential before drawing conclusions from any single PSA result. The medical understanding of
For the
prostate-specific
public, the most
antigen
useful
has
approach is
evolved
to
through
focus on
decades of
informed
research and
discussions with
clinical
healthcare
observation.
professionals. Don't
PSA
interpret laboratory
testing was
numbers in
introduced into
isolation.
clinical practice in the late 20th century as a tool to help identify potential prostate abnormalities. Over time, large-scale studies and public health reviews have clarified both its usefulness and its limitations. According to the National Cancer Institute, part of the U.S. National Institutes of Health, or NIH, PSA is a protein produced by both normal and malignant prostate cells. Because both cell types produce this protein, PSA testing cannot independently determine whether cancer is present. Instead, the test serves as an indicator that further evaluation may sometimes be appropriate. Research summarized by the Centers for Disease Control and Prevention, CDC, also notes that PSA levels may increase due to several non-cancerous conditions, including benign prostatic hyperplasia and prostatitis. These findings have been confirmed in multiple observational studies examining prostate health in aging male populations. Large population-based research has also examined the benefits and limitations of PSA screening programs. A major European clinical trial, known as the European Randomized Study of Screening for Prostate Cancer, published in the New England Journal of Medicine, followed hundreds of thousands of participants over multiple years. The study found that PSA-based screening could contribute to earlier detection of prostate cancer in some cases. However, the research also highlighted an important challenge. Many prostate cancers detected through screening grow slowly and may never cause symptoms during a person's lifetime. This phenomenon is sometimes referred to in the medical literature as overdiagnosis, meaning that screening may identify cancers that would not have affected long-term health if left undetected. Reviews published in journals such as The Lancet and BMJ have discussed how overdiagnosis can lead to additional medical procedures that may not always provide clear benefit. For this reason, several public health organizations emphasize careful interpretation of PSA results. The U.S. Preventive Services Task Force, whose recommendations are informed by extensive scientific review, currently suggests that decisions about PSA screening should involve individualized discussions between patients and healthcare professionals. This recommendation reflects evidence indicating that screening decisions may depend on factors such as age, personal risk profile, and overall health status. Similarly, guidance from national health authorities in multiple countries stresses that PSA testing should be interpreted alongside other clinical information. These include physical examination findings, family history, prior PSA trends, and when appropriate, imaging techniques such as prostate MRI. Taken together, the scientific evidence shows that PSA testing remains a valuable tool in prostate health assessment. At the same time, it is most effective when used as one component of a broader clinical evaluation rather than as a standalone diagnostic test. To understand why PSA levels can rise, it helps to look at what is happening inside the prostate at the cellular and physiological level. The prostate is a small gland located below the bladder and surrounding the urethra. Its primary biological function is to produce components of seminal fluid, which help transport and protect sperm during reproduction. The cells that make up the prostate gland naturally produce prostate-specific antigen, PSA, as part of this function. Under normal physiological conditions, most PSA produced by prostate cells remains within the prostate itself and enters the seminal fluid. Only small amounts typically pass into the bloodstream. Blood tests measure this circulating PSA. When PSA levels rise in blood tests, it often reflects changes occurring within prostate tissue. One important mechanism involves prostate growth over time. As men age, the prostate commonly undergoes a process known as benign prostatic hyperplasia, BPH. In BPH, the number of prostate cells gradually increases. Because PSA is produced by prostate cells, a larger prostate naturally has a greater capacity to produce PSA. This means that PSA levels may increase even when the tissue remains entirely non-cancerous. Another biological mechanism involves inflammation. Inflammation of prostate tissue, medically called prostatitis, can alter the permeability of the prostate's cellular structures. When inflammation occurs, microscopic barriers that normally limit PSA leakage into the bloodstream may become more permeable. As a result, more PSA can enter circulation, temporarily raising measured PSA levels. This inflammatory process may occur due to bacterial infection, immune responses, or sometimes without a clearly identifiable cause. In many cases, inflammation-related PSA elevations are temporary and may decline once the underlying condition resolves. Hormonal regulation also plays a role in prostate biology. The prostate is influenced by androgens, particularly testosterone and its derivative dihydrotestosterone, DHT. These hormones regulate prostate cell growth and function. Over time, hormonal signaling can stimulate gradual enlargement of the prostate, which in turn affects PSA production. At the cellular level, prostate tissue is composed of multiple cell types, including epithelial cells, which produce PSA, and stromal cells, which provide structural support. Interactions between these cell types are influenced by hormonal signals and local growth factors. When prostate cancer develops, the biological changes can differ from benign enlargement. Cancer cells may disrupt normal tissue architecture, and this disruption can allow additional PSA to enter the bloodstream. However, the relationship between cancer and PSA production is not perfectly consistent. Some prostate cancers produce relatively large amounts of PSA, while others produce comparatively little. This variability is one reason PSA levels alone cannot determine whether cancer is present or how aggressive it may be. Another factor influencing PSA levels is mechanical pressure or manipulation of the prostate. Activities that temporarily stimulate the gland, including ejaculation, certain medical procedures, or prolonged pressure on the pelvic area, may cause short-term increases in PSA. These elevations usually return to baseline after a period of time. Finally, the relationship between prostate volume and PSA concentration is often evaluated using a concept known as PSA density. This measure compares the PSA level in the blood with the physical size of the prostate gland, usually assessed through imaging. When physicians interpret PSA values, understanding the gland's size can provide useful context for evaluating whether the PSA level appears proportional to the amount of prostate tissue present. Taken together, these biological processes illustrate why PSA is best understood as a marker of prostate activity rather than as a direct indicator of a single disease. Changes in PSA reflect underlying physiological events occurring within prostate tissue, and those events may have several possible explanations. When physicians evaluate PSA levels in prostate health, the goal is not simply to interpret laboratory values. The broader objective is to understand how prostate conditions may influence long-term health, functional well-being, and overall quality of life. Several prostate conditions associated with elevated PSA are relatively common, particularly as men age. Benign prostatic hyperplasia, BPH, is one of the most frequently observed conditions. In many individuals, BPH progresses slowly and may lead to urinary symptoms over time, such as reduced urinary flow, increased nighttime urination, or a sensation of incomplete bladder emptying. While these symptoms can affect daily comfort and sleep patterns, BPH itself is not cancer and does not typically shorten life expectancy. In other situations, elevated PSA may lead physicians to investigate the possibility of prostate cancer. Prostate cancer is among the most commonly diagnosed cancers in men worldwide. According to global cancer statistics summarized by public health organizations, many prostate cancers grow slowly and remain localized to the prostate for long periods. In such cases, physicians may recommend careful monitoring rather than immediate treatment. However, some prostate cancers can behave more aggressively. When cancer cells grow rapidly or spread beyond the prostate, medical treatment may become necessary. Early detection in certain cases can help guide treatment decisions that aim to preserve both longevity and quality of life. The potential long-term effects of prostate disease also depend on how conditions are managed. Treatments for prostate cancer, such as surgery or radiation therapy, may carry potential side effects that affect urinary function, sexual health, or bowel function. For this reason, medical teams often weigh the potential benefits of treatment against possible impacts on long-term well-being. Importantly, not every elevated PSA level leads to a diagnosis of cancer, and not every diagnosed cancer requires immediate intervention. Clinical decision-making often focuses on balancing early detection with avoidance of unnecessary procedures. From a long-term health perspective, prostate evaluation aims to support informed decisions that consider both disease risk and overall quality of life across the aging process. Kiba noi tiep, toisiviet fansao, expert consensus va official recommendations, haitram nam moijen batram words, baugom huang dentu, USPSTF, American Urological Association, National Cancer Institute. Over the past 2 decades, professional medical organizations have carefully reviewed the scientific evidence surrounding PSA testing and prostate cancer detection. As a result, most modern clinical guidelines emphasize individualized decision-making rather than universal screening rules. The American Urological Association, AUA, one of the primary professional organizations guiding urological practice, recommends that decisions about PSA-based screening be made through shared discussions between patients and healthcare professionals. According to the AUA guideline panel, these conversations typically consider factors such as age, family history, overall health, and personal preferences. The organization notes that PSA testing may provide meaningful benefits for some men, particularly those within certain age ranges who are at increased risk. Similarly, the U.S. Preventive Services Task Force, USPSTF, has concluded, after reviewing large clinical trials and epidemiological data, that PSA screening decisions should involve individual choice informed by medical counseling. Their recommendation reflects evidence showing that screening can sometimes identify prostate cancer earlier, while also acknowledging that screening may lead to additional diagnostic procedures that may not always be necessary. International public health organizations and cancer research institutions express comparable positions. The National Cancer Institute, NIH, emphasizes that PSA testing should be interpreted alongside other clinical findings rather than used as a standalone diagnostic measure. In practice, physicians often consider PSA trends, physical examination findings, family history, and imaging results before recommending further steps such as prostate biopsy. At the same time, experts recognize that several areas of prostate screening remain under ongoing scientific investigation. Researchers continue to study improved imaging methods, genetic risk markers, and strategies for distinguishing slow-growing cancers from more aggressive forms. Overall, the current expert consensus reflects a balanced approach. PSA testing remains a valuable clinical tool, but its interpretation is most effective when integrated into a broader, individualized medical evaluation. For members of the public who encounter information about PSA testing or prostate health, the most useful approach is often to focus on informed discussions with healthcare professionals rather than interpreting laboratory numbers in isolation. PSA testing is one component of prostate health evaluation, but medical decisions about screening or further investigation are usually based on a broader set of factors. These can include age, family history of prostate cancer, prior PSA trends, urinary symptoms, and overall health status. Because these factors vary widely from person to person, individualized medical guidance remains important. Public health organizations generally encourage adults to maintain regular communication with their primary care physicians regarding preventive health. During these conversations, individuals may wish to ask about the potential benefits and limitations of PSA testing and whether screening might be appropriate in their particular circumstances. General health practices that support long-term well-being may also contribute to prostate health as part of overall metabolic and cardiovascular wellness. These include maintaining a balanced diet rich in vegetables and whole foods, engaging in regular physical activity, managing body weight, and moderating alcohol intake when appropriate. These lifestyle factors are widely recognized by health authorities as beneficial for general health, although they are not specific treatments for prostate disease. Individuals who receive a PSA result that appears elevated may find it helpful to discuss several questions with their healthcare provider, such as how the value compares with previous tests, whether additional evaluation is recommended, and whether repeat testing might provide more context. These conversations help ensure that health decisions are based on medical evidence, personal risk factors, and professional guidance rather than isolated laboratory values. Understanding prostate health often begins with a simple laboratory result, but meaningful interpretation requires a broader medical perspective. PSA testing provides useful information about biological activity within the prostate, yet it does not function as a definitive diagnosis on its own. Instead, it acts as a signal that may prompt further evaluation depending on a person's overall clinical context, age, medical history, physical examination findings, imaging results, and PSA trends over time all contribute to how physicians interpret these results. Medical research over the past several decades has helped clarify both the value and the limitations of PSA testing. When used thoughtfully and in combination with other clinical tools, it can assist physicians and patients in making informed decisions about prostate health. For individuals navigating questions about PSA results, one of the most constructive steps is maintaining open communication with qualified healthcare professionals. Shared discussions allow medical decisions to reflect both scientific evidence and personal health priorities. With accurate information, thoughtful evaluation, and appropriate medical guidance, prostate health can be approached with clarity rather than uncertainty. Medical disclaimer, 100 to 120 words, separate from main content. The information presented in this content is intended for educational and informational purposes only. It does not constitute medical advice, diagnosis, or treatment. Health information discussed here reflects general scientific understanding and may not apply to every individual situation. Decisions regarding medical care, screening tests, or treatment options should always be made in consultation with a qualified healthcare professional who can evaluate personal medical history, symptoms, and risk factors. If you have concerns about prostate health, PSA levels, or any related medical condition, please speak directly with your physician or another licensed healthcare provider. Do not delay seeking professional medical care based on information presented in this content.